and you see perhaps how the Americans, the Germans, the Europeans do awake craniotomy. There's a lot of technology, very imaging heavy, a lot of personnel, neuropsychologists, speech pathologists, that it's really a very advanced technique. Actually, the way I learnt to do awake craniotomy and the way I continue to do it is very simple. It's me, my anaesthetist, and an Ogerman stimulator. And I really do very little else. And yet my review of my results are that they're very much the same as anything in the literature. So I get an idea that awake craniotomy is easy because this is a 3200 BC Neolithic skull. Obviously no anaesthesia in the Neolithic period. And this patient has had an awake craniotomy and there's even healing. So this patient survived their awake craniotomy, probably not done for a brain tumour. But I think it's become clear that awake craniotomy with intraoperative mapping, the whole point of it being awake is that you can map the brain and you can do functional testing while removing the tumour, is really become the gold standard for tumours in eloquent areas, even vaguely, eloquent areas. I use awake craniotomy all the time. Reduction in late deficit and increased extent of resection. And this very large meta-analysis, which is a little old now, but which still rings true, very large meta-analysis showed that you remove more tumour with a lower rate of long-term deficits if you use awake craniotomy. So I think it's really becoming the standard of care. And in fact, this was an interesting paper from Mitch Berger, which looked at survival based on whether the surgeons thought the tumour was eloquent or not. So the worst survival was right down here, both with patients whose tumour really was eloquent, but also patients whose tumour was presumed to be eloquent but was not mapped. So if you make a decision in advance that the patient's tumour is in an eloquent region, but you don't check that first, then you doom your patient to poor survival. The survival was a little worse for a patient who was false eloquent, as in the surgeon thought it was eloquent, but it wasn't. But it was much better than if they just assumed. So if you think an area was eloquent and then it's not, you can get more tumour out if you map. And then if it's truly non-eloquent, then obviously the survival's best because the most tumour can be removed. But assuming in advance that your patient's tumour is in an eloquent region can actually reduce their survival. So why would you not do an awake craniotomy? Well, I think that one thing is patient discomfort and fear, and that's changed in Australia over the years. When I first came back from the United States in the early 2000s, many Australian patients were like, no, I'm not having an awake operation. In fact, the Americans were right into it. Yes, do it awake, go. But the Australians were much more reticent. Now it's really got into the public imagination, and most Australians will often come to me asking for awake surgery. I think a big one is surgeon and anaesthetist fear. Surgeons often don't like doing it because they actually have to talk to the patient. Surgeons are often not good at talking to the patient, but that's also true of anaesthetists. There's a little learning curve. There's a little bit of equipment, but, the stimulator's only about 5,000 Australian dollars. That's not a lot of money compared to a lot of the kit that we have. And, of course, there are some patients who are unsuitable. So I mostly do this operation for low-grade gliomas. The big thing is that these are, of course, extremely variable tumours, and deciding which patients should be operated and which patients should be operated awake is really the difficult thing. But how do I decide? Well, these are the things I think of in advance and that I tell the patient. I tell the patient that there's no stable low-grade glioma. I see many patients who've seen surgeons over the years and the surgeon said, oh, yes, the tumour's stable. Yes, the tumour's stable. Yes, the tumour's stable. And then all of a sudden they say, oh, the tumour's grown. And yet, if you look back over the scans, the tumour has actually grown a couple of millimetres every year. The surgeon just didn't want to acknowledge it. These tumours are always growing, and the average growth is 4 millimetres a year, but it ranges from 1 to 12 millimetres a year for a low-grade glioma. You don't know when the tumour is going to progress to malignancy, but it will happen. But you can't tell the patient you know when it'll happen. You cannot determine tumour grade from the preoperative MRI. You can get a pretty good idea, but at least getting a biopsy is really important. You cannot determine eloquence, particularly for speech, from the preoperative MRI because the tumour moves eloquent cortex. And the evidence for associating extent of resection with survival is now evolving and strong. So removing as much tumour as possible will improve their survival. So that's what I tell the patient. They're the steps that I go through when they say, well, why should I have a surgery and why should I have it awake? And then how do I decide what to do? Well, I have to have a preoperative assessment of the patient's risk, their clinical, their radiological, and sometimes if you've got a previous biopsy, their histopathology. I have to have detailed and often repeated discussions with the patient. This is often a more than one discussion to say that my bias is to favour aggressive resection with mapping, and that's what the evidence would show, but other surgeons would say something different. And then I have to apply the evidence that I have to that patient in that situation. That patient may not be ready for a large resection, but only want a biopsy because of other life events, for instance. So it's always a discussion with the patient. What are the essentials to do an awake craniotomy? The biggest essential is to make it common. If you only do an awake craniotomy once every 3 months or once every 6 months, you will not be good at it. You need to make it common. You need to do it often. Careful patient selection, careful patient education. So both me and my anaesthetist go and talk to the patient extensively about what will happen. Careful team selection. This is not the operation to do with the brand new scrub nurse, because you can't be trying to teach someone what they're doing at the same time as trying to keep your patient calm. You can't be yelling that, no, that's not what I use, if you have an awake patient. And careful team education. So making sure that everyone in the team knows exactly what's going to happen. And unfortunately, I hate to admit it, but the most essential part of an awake craniotomy is the anaesthetist. So this is my anaesthetist. This is Brad Hockey. And I really try and not do an awake craniotomy unless he's available. I really hate doing it with anyone else because we have such a good teamwork going and he's so good that I think the anaesthetist is actually your most important tool, and you should find an anaesthetist that you work well with and only work with them. That's very difficult. You've got to buy them coffee. You've got to take them on holidays. You've got to be really nice to them so that they'll keep working with you. Things that I don't use that a lot of people do, I don't use preoperative tractography or functional MRI. I know a lot of people do, and it's not wrong to do it, but if you don't have it available, that's what the mapping's for. So, you know, this is me asking someone, one of my patients came with this, and where's Broca's area? Well, number one, I don't believe that Broca's area exists. But number two, that's where I thought it was going to be. It's not really telling me that much. So in many cases, I think the functional mapping is not that useful. And, you know, in advance, once I've started to remove this tumour, of course, this imaging is a complete waste of time. But doesn't mean it's wrong, but I don't bother. Anesthetic technique, obviously some antiemetics, anticonvulsants, oxygen, access to intubate if needs be, but we haven't had to do that. So in all of our hundreds of cases, we have not had to do that. We give the patient a little bit of analgesic just at the start, some fentanyl, and we use largely dexmedetomidine is the drug that we use, but you can also use propofol and also some clonidine to keep the blood pressure down. And these are all very good at reducing anxiety. Do not use benzodiazepines, as they disinhibit the patient and make them not very cooperative, even though they're good anxiolytics. So we put the patient completely to sleep with fentanyl and with propofol, and we put the pins in, infiltrate the pin sites, and infiltrate the scalp incision. I don't use a urinary catheter anymore. We just give the patient a bottle or a pan to use on the table if they need to. So because especially men, they really go nuts about having a catheter in. So best just to leave it out and let them pee in a bottle if needs be. We let them awaken in the pins and they stay awake. So I use an awake, awake, awake technique. We do not put the laryngeal mask in. We don't have the patient really asleep for any part of the operation. We don't use asleep, awake, asleep. I find that it takes so long for the patient to wake up when we get to the mapping that we're better just to get it all done. I don't use preoperative scalp blocks while the patient's awake because they are so anxious by the time the anaesthetist has stuck the needle into them 20 times. So we do that when they're under the propofol. So this is our patient having woken up in the pins. We've marked out the incision. You can see all the points of infiltration there. There's my anaesthetist chatting away, and we've just while we were getting ready, and then we've prepped. He's giving him a neck massage because the patients often feel that they're suspended in space and they're trying to hold their head up, and so it gets a little uncomfortable. So we have to get them ready. Obviously, this is what it looks like on the surgeon side, and that's what it looks like on the anaesthetist side. Very standard setup, except there's a few tricks. You need to have the overhead table closer to you so that there's a window for the anaesthetist to get to the patient's face underneath. So it looks something like this. See, this patient's having a great time. We often take photos of the patients during their operation so that they can see what they look like. So you have a cave there, but you've got the overhead table very close so that you can really see the patient's face well. We have lots of tricks that we have to make sure that the patient remains comfortable. Of course, one is to stop people from walking into the operating theatre and saying something stupid while the patient is awake, knowing full well that that's what people tend to do. But we have a little nose scratcher for the patient. We put lip balm because their mouth gets dry. We allow them to take sips of water by from the end of a wet gauze. All of these things to make sure that the patient remains comfortable through the operation, not too hot, not too cold, not nauseous, etc. The surgical technique is very standard. Frameless stereotaxy, Kuzar, they're all our little tricks that we've got there. We cut off the top of the oxygen mask so it just sits down here and the oxygen wafts up because it's less claustrophobic. And all the way through, I'm explaining to the patient what I do. This is what the drill sounds like, foot on the drill, and they cope with it very well, awake through the whole thing, the craniotomy, everything. The craniotomy should be enough to expose the cortex for adequate mapping, but I'm not like Hugh Defoe. I don't take off the whole half of the head and map everything, just what I need. And pain is usually not a problem. The drill, heat from the drill on the dura can be painful, so we use ice cold wash for that. And dural manipulation can be a little painful. But generally, if you say to the patient, you're going to have a little headache now as you lift the bone flap, nothing bad is happening. It's over in 30 seconds and they cope very well. So for a tumour like this is the exposure, enough of the inferior frontal lobes that I can find a window to get through to. Then I do stimulation with the Ogerman stimulator, looking for that window. They're my settings. I've seen every other setting in the universe. I don't think it matters. There's lots of different ways of doing this. I stimulate from 1 to 6 milliamps, no higher than 6 milliamps, or you start to get cortical spreading. The cortical stimulation, basically motor, is simple, abnormal movement, test power, and for speech is basically looking for speech arrest, and for counting and naming. And sensory, you're looking for paresthesia or numbness. You need to have a good understanding of brain anatomy to do this properly, but also to understand how it may be distorted by the tumour. And I'm not going to go through that. The functional testing needs to be by someone competent. It doesn't have to be a neuropsychologist. It doesn't have to be a speech pathologist. My anaesthetist does our functional testing, and we have a very good protocol for doing that. So for speech, the best test is conversation. So we have quite a long list of questions that we ask, and we get the patient to talk through those questions. Tell me about where you met your wife. Tell me the steps in your job, exactly what your job is and what you do. Tell me about your eldest child, which means that they have to use working memory, long-term memory, naming, all of those things, as well as we do a little bit of counting and object naming, but those things are not the main thing. And while he's testing speech, I'm listening. And when there's a little stumble, a word missed, whatever, we stop, we wait, we wash, but we know that that might be the time that we need to stop. Obviously, for motor, it's very simple, frequent testing. So that's the window that I had to get into that tumour. That's what it looks like. What problems can you have with awake craniotomy? Well, a lot of people say that they think that you'll limit the extent of resection due to a deficit that recovers, particularly premotor. The literature would not say that that's true. In fact, that extent of resection is better if the tumour's done awake. Seizures, the literature says 5 to 20%. My rate was about 15%, but we've managed to drop that back down to about 8%. They're usually easily controlled with ice-cold saline irrigation. But if you get a Todd's paresis, that's a real problem because it means that that's what you wanted to test. A sudden onset deficit can be quite distressing for both you and the patient, and that's often a vascular deficit. The literature conversion rate to GA is 1%, but I've only had to do that once, and that was back in the early 2000s, 2002, so it hasn't happened since. So this patient, who I thought I had a lovely resection for, of course, got a hand-face weakness during the surgery, and that was related to this stroke. So what are my results compared to the rest of the literature, despite my simple technique? This was early on. We've added to it. It hasn't changed. Young patients, because they're largely low-grade glioma, positive mapping in just under 50%. You get a greater extent of resection if you have negative mapping. And significant surgical complications. An extradural is something really to watch for because it's such a big resection cavity. We've done volumetric analysis of the tumours that we've removed. Interestingly, the WHO grade of what we thought were grade 2 tumours, in the end, only 72% were grade 2 tumours and 19% were grade 3 tumours. And so you can't necessarily tell from imaging what the grade is. Our neurological outcomes, so we've got a 5% deficit rate at 12 months. Two of those 4 patients, so 2 of those were non-limiting speech deficit that the patient could still work. One was some foot spasticity, so that the patient could not wear high heels but could otherwise walk normally. And one was a serious deficit in a patient who got an ACA stroke. Our extent of resection overall is 82%. Which is, if you look at this in comparison to the literature, 82% of gross total resection is very good in comparison with the literature. So I'm going to stop there, and hopefully we've got Matt to come next. We're going to do the questions at the end. Thank you.